Hi, good morning. My name is Dennis Reyes. I'm one of the neurology residents from the Cleveland Clinic in Florida. We'll be talking today about diagnosis of epileptic syndromes. We want to go to the first slide. Okay, so for the first slide, all right, I think we should talk about what is consciousness. It's just the basic concept, and it's pretty much defined as the quality or state of awareness or of being aware of an external object or something within oneself. And it has been previously defined as well as sentience, awareness, subjectivity, ability to experience or to feel. And it's pretty much composed by three main features, which are alertness, attention, and awareness. So our alertness is basically what you see in you can see in every single patient or everybody around you, in the sense of having their eyes open. But that doesn't mean that they're paying attention or they're aware of their environment. So how do you know that? It's basically, that's when you start talking to them, and by communication and other kind of stimulus, and in response of them to you, you'll notice that there's attention, there's awareness, and I hope everybody's paying attention right now. So for the next slide, classification in epilepsy, I think we should start with that. So things have changed over time. Back in 1981, 1989, seizures in general, they were called pretty much generalized seizures or generalized epilepsy, focal seizures, focal epilepsy. Now that has changed over time, in the sense that now, by the new classification from 2010, which is available in there's basically a website here, an online library that you guys can access, and it's been described by Burke et al. In Epilepsy. Pretty much the concept has been trying to make it more concise and more objective oriented. Initially, there were generalized seizures were described as those with in which the first clinical changes indicate initial involvement of both hemispheres. Now are more conceptualized as originated at some point within and rapidly engaging bilaterally distributed networks, because it basically can start at one point and spread throughout the whole brain. The term for generalized epilepsy itself has been largely abandoned at this point. Again, it's only called generalized epileptic seizures. For focal seizures, that I think it's important to mention that they used to be called partial seizures. Like everybody calls partial seizures, and simplex or complex partial seizures. Those kind of concepts has been wasted for now, and they're pretty much calling this as a focal epileptic seizure, which are pretty much conceptualized as originating within networks limited to one hemisphere, and this may be discretely localized or more widely distributed. And again, focal epilepsy, that term has been abandoned. So let's talk about partial or focal. Like I said, is it partial? Is it focal? What we're calling right now. So again, the new guidelines, what we used to call the simple partial, it used to be divided by motor signs, sensory symptoms, autonomic symptoms, and psych. Now it's more as a it's a focal seizure, and without impairment, but it's subdivided without impairment of consciousness or with impairment of consciousness or awareness. For the first description, you do have you can have motor or autonomic components. Sensory or psychic phenomena can happen as well. And for the partial, evolving to secondarily generalized seizures, which we'll be discussing more how did that happen. But basically, certain patient will have a susceptibility to develop seizures starting from one part of the brain, and then will definitely spread throughout both hemispheres, resulting in generalized seizure, with whether it's a tonic, a clonic, or a tonic-clonic event, and we'll get to that more. But in concept, basically, is the focal seizure is evolving to a bilateral convulsive seizure, which is being highlighted here in the slide. For the next slide, basically, this is what we typically call a normal EEG. Is this a little bit of description? Basically, we'll call it double montage, and then it's divided. You can see the color red and blue. Basically, what is shown here is the side of the brain wave where it's coming from. So the even numbers, FP2A, they belong to the right side, and basically the odd numbers belong to the left side. F stands for frontal, is a very anterior point in the frontal area, and T stands for temporal, and O stands for occipital. So as you can guess, those leads are tracking around the head, from the front part to the posterior part of the head. C stands for more central region, and it's pretty much close to the vertex region, which is pretty much in the middle of the head. And then the description is pretty much like it says here, so it's connecting basically, or it's reading between 2 points in the head. And so what it tries to do is basically captures a brainwave from both points, and then gives you an average of what's happening from the electrical activity standpoint of the brain. And this is what it should look like, a normal brain. More in the posterior part of the head, towards the description in T602 and also T502, also P4, which is P stands for parietal, by the way, P402, and those are more in the posterior, which is it's important for us because we typically look at the area looking for the backgrounds. So the background of the patient, which on average it should be around between 9 to 12 or so, and then we count those waves, and if it's within the range, we say it's normal. Now, there's one way to increase that background, and it's by asking the patient to close their eyes. So once they close their eyes, the background will definitely be higher. If they open their eyes, some degree of dispersion occurs, and those brainwave, you won't be able to see it as good. And then what is this? This looks normal at all? I mean, definitely not. This is an example of a type of seizure, and basically it's completely disrupted. It doesn't look anything at all like the previous slide, and you can see pretty much the electrical activity is completely disrupted. Like I said, you can actually, if you take this page and flip it over 180 degrees, it's pretty much going to look the same. It's considering that it's so distorted. So let's talk about now focal epileptic seizures emiology. And basically, is a normal electrical discharge remains localized to a small population of neurons with the exponential potential to spread to nearby neurons. Now, there are definitely subdivided in those without impairment of consciousness or awareness, and we'll get into those that are with and the impairment of consciousness or awareness. But so the purpose of this picture here is, though it looks kind of funny, is basically to let you know that there is a topography basically in the cortex of the brain. So the brain, each part of the brain is controlling different parts of your body, and that's including the face, the mouth, tongue. That's why this guy has a big mouth and a big tongue, and the hands as well. So what it's trying to say basically is that there are high parts of the brain that highly involved in certain functions of the body, and one of them are the mouth and also the hands. So in regard to focal epilepsy, it's typically limited to one hemisphere. It's considered epileptogenic focus, typically discretely localized versus more widely distribution. It can be seen. The patient can describe something called aura, and aura itself, the word itself, comes from the Latin word breeze, which is a synonymous of focal or psychic seizure. It goes back in years and years ago when it was previously described. Typically lasts for a few seconds, and most commonly occurs in the temporal lobe as a rising epigastric sensation. You can have a deja vu or intense fear, and also palpitations. So deja vu, of course, probably some of you guys know about this, but it's something that you recall, but by some reason that you have seen that before, something that you're experiencing, you have experienced that before, and it's definitely something that the patient will describe to you as a deja vu. There's another kind of that we'll get to there as well. So the topographic distribution again of the cortex. This is pretty much an example. But this is part of the brain. Is this is a sample, a cut sample here. Basically, the top part of the cortex typically is in controlling the hip, the trunk as well. Then after that comes the arm. You can see the hand has a big territory in the distribution of the cortex. The face also carries a huge distribution in the cortex as well. There's a small spot for the tongue here, down here, and as you go in the inner side of the medial side, I would say, of the hemisphere, basically, that cortex is also controlling the food as well. I wanted to mention you, this is kind of important because there's something called a classic Jacksonian march, and it's been described as a simple partial motor seizure, which is a wrong term, since we're not calling anymore a partial seizure. Is more of a focal motor seizure. It's a rhythmic contraction that starts in the fingers, and so thinking about that, it will start in the area around the hand, and interestingly enough, will spread to the ipsilateral sides of the face, and then progress to the arm, and later also progress into the trunk, and also involve in the hip. And that's what the typical classic Jacksonian march is. Basically, it starts here, and as it's spread out wider and wider, it also involves the same side of the face and the same side of the arm, extending toward the lower extremities as well. So that's a good example. Again, the brain has a wide distribution of multiple areas, anatomically speaking, with certain functions. And so just going through the most important one, basically what you see here in the frontal area, which is more anterior aspect of the brain, this is called frontal lobe. Frontal lobe typically extends a little bit wider and also extends toward the central sulcus, which is this line right here. Okay, so basically the division between the blue color and red color, which pretty much subdivided the frontal lobe from the parietal region, which is a little bit more posterior here in the back of the brain. Now, even more posterior to the parietal region is what we call the occipital lobe, right here. And then this part here that is hanging just below the blue color and kind of this orange looking like color, and including the green part, is the temporal lobe. And it's a very important region because it's highly susceptible for seizures. and that's one of the areas that we always keep our eyes in, looking for possible seizures. So the color basically, just to let you know, this first part is called the premotor area, and it's important because it can give you a different type of seizure. What I'm trying to say here is this different, any seizure that comes from the different areas of the brain will definitely show, or the patient will feel different types of sensation, let's say sensation, or will experience different type of symptoms, let's put it that way. For the frontal lobe itself, whenever it's involving your eyes, there's a spot there, controls part of the movement of the eyes. Whenever there's a seizure coming from that area, will definitely give you some deviation of the eyes. If the part of the motor area, which is the part that controls your movements and moving the arms, moving the legs, you can guess for sure the seizure is coming from that aspect. It will definitely give you that kind of seizures of moving and contractions and that kind of thing. More toward the territory where the sensory is covered, where you actually can feel whether it's temperature, whether it's pain, whether it's a tingling sensation, that'll come from that blue region right here. And that's pretty much what the patient could tell you. More in the posterior aspect is the occipital lobe, which is in charge of controlling your vision. And you can guess, of course, that if there's any seizures coming from that area, the patient will have some visual symptoms. So, temporal lobe is also, part of it is involved in the auditory system. So they can hear voices, or have some sort of we'll call auditory hallucinations, but it's not necessarily hallucinations. So that's why sometimes we need to investigate more whether those symptoms could be related to a possible focal seizure. For focal epileptic seizure semiology, like I said, whenever it's coming from the somatosensory cortex, it can have numbness, warmth, or electrical shock ligands, and that can also be distributed in a Jacksonian march. So let's say in the same distribution that I mentioned before applies for not only the motor part of the brain, but also for the sensory part of the brain. So the Jacksonian march will start again in the hand and spread out to the same side of the face, then the arm, and then will ended up spreading down to the leg as well, either as a movement, abnormal movements, or basically as a sensory changes, including, like I mentioned, the numbness or the tingling sensation. There are special sensory seizures like visual, auditory, gustatory, which is mentioned. Other sensory seizures could be feeling cold, pain or desire to move, tingling feeling, stiff, pulling, pulsing, heaviness. There's multiple symptoms could be a seizure. Pretty much, you start reading about this, you think that everything could be a seizure. So autonomic, so it could be expressed as vomiting, sweating, pyrexia, pallor, that kind of thing. This is EEG just to show you what a focal epileptic seizure would look like in the EEG, and it's just pretty much showing this normal discharge. We call that spike followed by a slow wave, and it will pretty much be limited to just a few leads, and sometimes it can be translated in kind of the closer leads to this one. But you can see that the rest of the the leads will be spared, basically, showing a normal, we call a normal background or a normal EEG brainwave. A little bit more of this in regard to focal epileptic seizure semiology. Like I said, this guy here can have a focal motor just because it's coming from the precentral gyrus. It's again dividing the Remember, this is coming just from the, this is kind of pinky, but the prior slide was red. So any seizure coming from the area, especially let's say just coming from the arm, they will definitely have some tonic-clonic movements of the upper extremity. And let's say it's coming from the face, well, they'll have then some grimacing of the face, that kind of thing. It's coming from this guy is actually looking to the left side. That tells me that it's probably coming from the frontal eye field, which is in part in the frontal lobe, again, that I mentioned before. It should be a spot around here, an area of the cortex around here. And any abnormal discharges coming from that area will definitely force the patient's vision to look toward that side. Turn to the opposite, to the opposite side. And basically, what else? Then the seizures also coming from the sensory part, like I said, you can have tingling, sensation, that kind of thing. The visual part, again, there's an example is having some abnormal disturbances in their vision. It could be scotomas or flashes of light. They could be unilateral, they could be bilateral. From the auditory standpoint, they could hear ringing or hazing noises as well. And that's pretty much the pattern for focal epileptic seizures. Another examples is those that are accompanied with impairment of consciousness, and that can last for 1 to 2 minutes, but then the patient will tell you they remains confused from 5 to 10 minutes. Some of those seizures are called stereotyped automatism, like you can see the patient's lip smacking and repetitive swallowing movement or fumbling movement of the hand. They could have what called aversive seizures, which is the same example I put before with the guy looking to the left side. It's pretty much because it's a sustained force conjugate ocular, or basically the cephalic as well as the whole head, the eyes, and there's a truncal rotation to or lateral deviation from the midline, which is pretty much the frontal eye field that I mentioned before. There's also called there's another type of focal epileptic seizure is called fencing posture sign, and that's coming from the supplemental motor area, which in the prior slide I showed it's pretty much the area that is very close to the primary motor area of the cortex. You remember the color red, that was in charge of the primary motor cortex. A little bit toward the side, there was a orange kind of yellowish color. That's the supplemental motor area, and they will give you this type of seizure where patients will extend their arm, and the opposite arm then will be retracted and flexed above the shoulder. There's another description of epilepsia partialis continua, where you can have continuous focal motor seizure, describe a clonic movement that can last up to a month, actually, with preserved awareness. Why there's preserved awareness? Basically because it's a seizure very localized, very affecting the small territory of the brain. Therefore, it's not causing significant altering in the consciousness. And whenever you have a seizure, of course, that is starting to evolve and progress, affecting more and more areas of the brain, you definitely will have an impairment of consciousness. Now, you have a very focal seizure localized to, let's say, 1 centimeter, 2 centimeter area of the cortex of the brain. It should not affect your consciousness. So for generalized epileptic seizures, they were previously described as pretty much tonic-clonic, myoclonic, and there were the absence seizure. Now the new classification, they describe the tonic-clonic, but also in combination with myoclonic, and then they can have myoclonic and atonic seizures, myoclonic and tonic seizures, and we'll get to those terms in a while. I know they seem to be a little bit complicated, but You get a good explanation for that. So absence seizure, you might have heard about this before. And also spasms are being described as a part of the generalized epileptic seizure. So for the tonic-clonic seizure, basically, they typically involve both hemispheres at the onset or as the progression of a focal seizure that we mentioned before. Now, they can occur with little or no warning and clinically expressed as a grand mal. All right. For the tonic seizure, the description of tonic seizure basically is a sustained increase in muscle contraction lasting a few seconds to minutes, and this may include vibratory symptoms. So you see pretty much a patient found to be stiff, basically extending the arms, extending the legs, and there could be some shaky movement, but not much. Typically, it's just more of a muscle tension or rigidity, and that can last for just 1 or 2 minutes or so. The clonic seizures are kind of different. It's not necessarily the stiffness that I mentioned to you about. This is more of a repetitive contraction, which involve the same muscle group, and they can have a frequency of 2 to 3 cycles, and it's prolonged. So an example of what I was just talking about. So some patient will initially start with the tonic phase of the seizure. They can have an epileptic cry accompanied by cyanosis. They can experience urinary or bowel incontinence. You can sometimes find them with foaming coming from the mouth. That's because there is an increase salivation during that period of time. During the tonic phase, again, there's stiffness, but it's more of a generalized kind of picture, and it will be affecting the upper and lower limbs, and the back sometimes is arc, and that's been described as opistotinus. And there is another term that you guys might be able to look at that is called epistotinus, which is the opposite of what you're actually looking in here in the tonic phase. So for the clonic phase, basically it's the contractions of the muscles, not only affecting the arms but also the legs, and they can have eyes blinking as well, and the foaming from the mouth sometimes could be pinkish. Why is that? Because based on the tension of the masticatory movement, they typically ended up biting the side of the tongue. Sometimes the inner parts of the lower lips, but most frequently is the side of the tongue. And that's kind of one thing that we typically pay attention, because when we see this kind of sign, then especially during the physical examination, then we're pretty certain that we're dealing with a seizure here. Some interesting finding is you can have patient biting the tip of the tongue. So when the tip of the tongue, basically, that will tell us that sometimes a patient will try to not necessarily meaning have create the seizure itself, but is what we call basically non-epileptic seizures. What I was trying to say is that it's not termed either as a conversion disorder either, but so in their mind they will have a seizure. It's just too deep in their brain. But whenever you put lids in this kind of patient and record one of their event, sometimes you can pretty much notice that there's no abnormal brain wave activity. And then these patients occasionally will have biting on the tip of the tongue as part of their injury during the process of having this non-epileptic seizures, which is commonly found in, as I mentioned. At the end of the seizure, during this 1 to 2 minutes kind of period, which is typically the time of what we usually see whenever a patient has a generalized tonic-clonic seizure. Whenever it goes beyond 3 minutes, then we become a little bit more concerning, because they can go into status epilepticus, and that's kind of a little bit scary event. Also, if they tend to cluster, let's say they had a 1 to 2 minute seizure, and then they're of course they're confused afterwards, but then 10 minutes later they have another seizure. That's that's kind of concern for us as well, because then that can increase the chances of just the patient letting you know that it can at some point develop status epilepticus. And we get to that term as well. So the post-ictal stupor period, it can last anywhere from 30 minutes to 20 minutes. Sometimes it can last up to an hour. Now, whenever it goes beyond an hour or so, it's kind of like prolonged post-ictal stupor, and then that definitely needs to be assessed with further testing. Now, myoclonic seizure is been described as sudden, brief, and irregular contractions of muscles or muscle group of variable topography. Excuse me. Sorry. Single or multiple. Example, it could be a juvenile myoclonic epilepsy. Typically happens between 12 to 16 years old. It's being considered also as a generalized tonic-clonic seizure, can be present during this episode of myoclonic seizure. They're frequent in the morning, by the way, for this juvenile myoclonic epilepsy. This is an example of a picture that the lady dropping toothbrush and just early in the morning while in the bathroom, and that's kind of the typical description that we give in the clinic. You just go to the bathroom, and then they have this episode all of a sudden, and the EEG typically shows a 4 to 5 hertz spike wave complex, and it's pretty much a generalized pattern. It's not following just one single pattern. And they can have also polyspikes, and this is pretty much what it's showing here. You can see multiple, a lot of spikes going on here. You can actually count it 1, 2, 3, about 6 spikes or so. But again, it can be sometimes a 4 to 5 hertz spike wave, which is not typical. I mean, well, it could be this one, for example. You see a spike here, and then there's this kind of slow wave that follows the spike. That's what we kind of look for. Childhood absence epilepsy. This is a very interesting disease, and that it's very common basically, and you definitely will encounter this at some point. It's a generalized idiopathic entity. Age of onset is 5 to 8 years of old. Clinical presentation, like it says, absent seizures, occasionally associated with automatism, myoclonic, sometimes tonic or clonic features. Patient will typically start complaining of staring into the space with some loss of awareness, and they can last just for seconds. Just could be 5 seconds, sometimes 10 seconds, and then they come back right away. And I mean, they definitely lose track of time, and in that period of time. And one of the main complaints is basically a kid that is at school and is having a decrement, is not able to maintain track of the education, and then the teacher starts complaining about their grades. Their grades are coming down. So sometimes these entities are confused just by attention deficit hyperactivity disorder, but it's not, and it just needs to be properly assessed. The EEG can show called a 3 hertz spike and wave. And what it means is basically that it's in the 1 second period, you can count basically 3 times spike and wave complexes. And so an example here is between each line here. This is 1 second. This is pretty much a 10 for almost a 10-second page of well, if we include this bar as well, 10-second page. And you can definitely, you should be able to count here 3 spikes and wave within this range of 1 second. So that's the typical description of the EEG. And medication wise, Jose will be able to tell you about, but one of the most well-known medications is ethosuximide, and you'll hear about that more. For benign epilepsy with central temporal spikes, it's called BECTS. It's most common childhood epilepsy seizure, by the way. Age of onset is 3 to 12 years old. Typically affects the unilateral face and arm as tonic or clonic nocturnal seizures. They can have drooling and inability to speak. They're also called Rolandic seizures. Why? Because they come from the central area, central sulcus, or the Rolandic area, basically. You remember the colors that we talk about with the red color and the blue color. There's that area of red color where the motor cortex is the one that controls, again, the movement of your body, where the seizures are pretty much coming from that specific area. These patients or kids, pretty much they will have a normal cognitive development, and they can have a selective language processing disorders as well. Their EEG will typically look like a central temporal spikes, and this is pretty much the way that it looks like. Towards the center, the distribution of the EEG, even though it looks like generalized, you can see there's some space here spare, but pretty much paying attention more toward the Z area. Whenever you see a Z as in zebra here, it's pretty much because it's close to the vertex, and that can be part of it translated into that focus of the Rolandic area. Also toward the lateral aspect. So whenever there's the parietal can be affected as well. A little more of the central as well. Part of it, the frontal region, it can actually capture those kind of seizures. So it's pretty much on the side, top part, middle, and side of the head. You can definitely find those central temporal spikes. But interesting enough, more than 99% of children will completely remit from this entity, which is that's why it's called benign, because most of them will have a good, excellent prognosis. At some point, it's gonna resolve with no. Typically, these kids, like I said, normal cognitive development, and they won't have issues in the future, developing generalized tonic-clonic seizures, difficult to treat with multiple medications, and that kind of picture which kind of what we usually are scared about. In regard of infantile spasm, this one is a little bit tough entities for kids, and one of them is called West syndrome. It's a very aggressive, I would say, entity. Age of onset is typically between 4 to 9 months. They can have a sudden flexion or extension. They can have a mixed flexion extension, predominantly proximal or truncal muscles. Usually it's more sustained than a myoclonic movement, but not as sustained as a tonic seizure itself. So that's what is defined as spasm itself. It can be affecting the arms, legs, and trunk. It's been described as lightning or salam and jackknife attacks kind of thing, because they're pretty much sudden, although they last too short. And they're definitely associated with developmental regression, and a pathognomonic EEG is called hypsarrhythmia, which is pretty much the same pattern that I showed you at the beginning of the lecture. where you can see the whole distorted pattern of brainwave activity. Um, and this is the typical page. It's pretty much this one. It's the same one. I just flip it 180 degrees, and so you remember it's pretty much looking the same as it was looking before. So the triad, and the most important thing for this just the take-home knowledge about this is the triad of the infantile spasm, the developmental regression that is present in this patient, and the hips arrhythmia that I mentioned before with this very disrupted brainwave activity. The Lennox-Gastaut syndrome is another important disease that we need to talk about. And the age of onset is typically between 3 to 7 years. It accounts for 5% of childhood epilepsy. The most common cause is secondary to either tuberous sclerosis, you can have encephalitis, toxo, hypoxic ischemia. They would experience intractable tonic, atonic, or myoclonic. They do have also absence like or generalized tonic-clonic seizure. The triad is been described as a cognitive impairment with developmental delay accompanied by a typical EEG again. And there are two main descriptions from the EEG standpoint, and one of them is the sharp slow wave spikes with a frequency of 1.5 to 2.5 hertz. The other will be the electrodecremental response to drop attacks. So for the first one, you can see the first EEG. She's showing the pattern of a sharp slow wave spikes 1.5. So this one is definitely different than before the absence, the one that we described that I mentioned before for absence seizure. You can have the spike wave occurring within 1 second. This one you can have a very slow, the sharp slow wave, but it will be with a frequency of 1.5 minutes. You can see a whole sharp slow wave spike, or maybe half of it within that second period in the EEG page, basically. Now, the other one will be the electro-decremental response. These patients are one of the interesting clinical features is that all of a sudden they will lose the tone completely. They'll become atonic, basically, and it means that the muscles basically they will all of a sudden will become flaccid, and they will just pretty much drop to the floor. And that's one of the reasons most of them are recommended to wear helmets to prevent head injuries. So in the electrodecremental response, you can see this high increase slow wave activity, and all of a sudden there is a drop in the brain wave activity. It's pretty much like it's a silent period of time in the brain, and then the disrupted pattern starts back again. And during that period of time is when typically the drop attacks occur. It's very cool here. So this period of time is when the kid will experience a drop attack. Surgical syndromes, I think it was important to mention about. I was just gonna talk about the three main ones, especially the one from Mesial temporal lobe epilepsy with hippocampal sclerosis. I think at some point you guys are gonna be encountering this kind of entity. There's also Rasmussen syndrome and also gelastic seizures with the hypothalamic hamartoma. The first two slides, these are pretty much examples of brain MRIs. This is the front part of the brain. This is typically the right side of the brain. This is the left side of the brain. You can see the ventricles here. There is definitely a difference, if you guys can notice, between the right side and the left side. The left side looks a little bit, there's some changes going on, right? What we call in the MRIs is regard of intensity. You can see there's some atrophy going on here. and a little bit towards the anterior part of the brain, frontal lobe, and also in the posterior area. This is a pattern that's been described with the Rasmussen syndrome, and is usually accompanied by non-stop seizures. It has a very poor prognosis, to the point that the patient will need complete resection of that whole hemisphere to prevent the seizures to continue to happen. And for the gelastic seizure means a patient will have they will express their seizure as laughing. They will be laughing with no purpose, no reason to, and then they're pretty much translating the fact that it could be a small tumor coming out of the hypothalamic area, which is pretty much this spot here. And then you can see this is an example of a hamartoma. This is again a brain MRI, but this is a different section. This is a coronal view, which is pretty much you have a kind of like a transverse cut, and you can see the brain from a different angle. And so kind of in the deeper areas of the brain, there's this outgrowing tissue, or pretty much a mass that is coming from the hypothalamus, and that's been correlated to gelastic seizures. For the mesial temporal lobe epilepsy with hippocampal sclerosis, is the most common surgically treated epilepsy. Clinical seizure often begin with rising epigastric sensations, smells, fear. They could have deja vu or Hamais vu, which is pretty much the opposite of deja vu. And they can progress to loss of responsiveness. They can have behavioral arrest, orofacial automatism, ipsilateral hand movement, and contralateral arm posturing. That's a typical description for temporal lobe epilepsy, which I mentioned before, is pretty much the lobe with high preference for to develop seizures, high risk for having seizures, to progress into seizure. Basically, any injury at that level, temporal lobe, like including encephalitis or trauma, any surgeries or any vascular abnormalities around that area, especially toward the medial part, which will be kind of on this area, I would bet they would express with seizures most of the time. Most common associated pathology is mesial temporal sclerosis, which for that we'll typically get an MRI with this, again, the transverse cut, which we call it coronal cut. And then we were looking into pretty much into the hippocampal area, whether there's any changes. And the changes that we're looking into, whether it's more, it's kind of brighter, is it shrinking kind of pattern that we're seeing there, or is it outgrowing, is it increasing size, or small in size, or is it increasing the signal of the actual sorry, actual imaging. And so it's pretty much the most common surgical procedure for mesial temporal epilepsy. This is a typical EEG pattern for the kind of etiology from the mesial temporal lobe epilepsy. You can see the firing, and these leads are mainly localized toward the temporal lobe. You see the other parts of the brain will be spare. So this is an example. Sorry, an example of a patient who had mesial temporal hippocampal sclerosis and had a resection of the temporal lobe, and there is a great response to in these patients after surgical removal of that part of the brain. And what we're looking into is pretty much initially this patient will be probably extensively assessed in regard to their seizures. With we could be monitoring this patient for a long period of time in the hospital setting, typically will stop their medication and make sure the seizures are coming from the same side, the same region, and they will further characterize by doing further more imaging studies and to make sure where the seizures are coming from. They make sense with the findings on an MRI, and then at some point, then we consider whether medications are not working anymore. For example, what's been described is if the patient fell to 2 anti-epileptic drugs, and falling to 2 anti-epileptic drugs means that they could have, while on the medication, they can have a breakthrough seizures, or they could have side effect from the medication, not able to tolerate it. So if they fail 2 medications, they'll definitely be a surgical candidate. And these surgeries has a excellent prognosis. 68% of the patient after 2 years could remain seizure free. Epilepsy with structural metabolic causes, as I wanted to mention to you for you guys to know. There's structural abnormalities related to abnormal developmental during the initial periods of the brain development, where the migration of the cells to the cortex are abnormal, and they stay in one area of the brain instead of migrating, so that causes the example of heterotopias. There's some other etiologies like tuberous sclerosis, Sturge-Weber syndrome. There are tumors, metastases like glioblastoma, meningioma, infections like herpes simplex encephalitis. This will typically again affect the temporal lobe. Autoimmune inflammation, it could be spread out. Trauma, like motor vehicle accident kind of thing, can affect the frontal lobe, also the temporal lobe, just because the impact over the brain can create a lot of movement inside the skull and injure the brain. Angiomas, of course, perinatal insults, ischemia of the brain whenever this patient had a cardiac arrest, and for more than 10 minutes or a certain period, long period of time, there's not enough oxygen going to the brain, not enough blood flow. As a result, there could be an injury, and actually could be diffuse, and as a result, and then there's the neurons, so it could be very irritating and produce seizures. Stroke is actually the most common cause in the elderly, and for seizures, and again, it's an insult to the brain, that part of the brain will be damaged, and going through the repairing process, those neurons they lose their proper arranging, and also they could become irritable, and as a result definitely cause seizures. And dementia as well has been associated with seizures. Status epilepticus is at least 5 minutes of continuous seizures, or 2 or more seizures, between which there is an incomplete recovery of consciousness. I think I mentioned to you guys this a little bit later. Incidence in the general population is about 20 to 40 in 100,000 per year in the United States. It's pretty much a misfiring of the of the whole brain, and it's pretty much ongoing, continuous, persistent. There could be the ictal, so the motor activity could be divided into convulsive seizures or non-convulsive seizures. So this is one of the things that we're concerned about, because sometimes we see a patient that just recently had a seizure, but then during this post-ictal period of confusion, sometimes it can be too prolonged, lasting an hour, maybe more than an hour, 2 hours, 3 hours. And then this is one of the things that we should be concerned about in the sense of that patient that is not actually convulsing. It could be actually having abnormal brainwave activity, meaning seizures, meaning ictal EEG activity. And that's what I just tried to show here. And there are actually several patterns. You have a generalized pattern, which could be tonic-clonic or clonic, or you can have focal activity of the abnormal activity of the brain. So again, there's no motor activity during that period of time, but the prognosis is very poor if we don't find that out really quick and treat the patient. So causes of status epilepticus, and I just going to mention the most common one in the adults are stroke, including hemorrhagic, low antiplatelet drug levels, like patient with non-compliance, and remote brain injury with congenital malformations. In children, one of the most common ones are low antiplatelet drugs, and also febrile seizures have been associated with the status epilepticus, and 40% of the cases that could have a remote brain injury or congenital malformations has been associated as well in children. For status epilepticus, the absence of significant improvement in the level of consciousness 20 to 30 minutes after the cessation of convulsions, like I said, should definitely raise the concern and post-convulsive, non-convulsive status epilepticus, and that's why you would see doctors putting EEGs just to make sure this patient with a prolonged status of confusion is not actually having a persistent non-convulsive seizures, which is called pretty much status epilepticus. And some of the symptoms that they can have and the way that they could be expressed is with agitation, aggression. They can have anorexia, aphasia, catatonia, coma, confusion, delirium, delusions, some lethargy, psychosis, even singing here. Some abdominal sensation they can be complaining about, including sometimes chest pain. I wouldn't call this alone. I mean, these symptoms alone, they typically they don't translate into the fact that it could be a seizure per se, but if you put the chest pain together with some other symptoms like, say, anorexia, or maybe some delusions or confusion, then you might want to look into possible status epilepticus. Motor-wise, you can have some eye blinking, eye deviation. You need to look for that. We've seen that very common especially in the ER. Facial twitching could be